Okay, hi everyone. This is going to be part two of digital imaging, and where we left off with gradation processing. So the idea here is once a volume of interest is chosen, these pixels can then be compared to the lookup table. So what has already happened, if you remember, is we've gone through a portion of the processing where spikes are removed, so raw radiation, for example, and barium, which might be a tail, is taken away and not going to be processed. And then we're left with several pixels, right? But we can essentially move our volume of interest. You see here at the bottom, volume of interest there, volume of interest over here. That's moved to better highlight the type of exam that we're doing. So, for example, below, if you look at histogram A, the volume of interest was moved towards the left to represent the volume that is bony tissue versus soft tissue on the right. That will help eventually during our rescaling process. So processing errors can occur if the histogram at the processing time does not match the actual histogram that was acquired during the image. In other words, you have a mismatch. So errors can also happen under extreme exposure conditions where you use either a very large exposure or captured in the image is a prosthesis or shielding that is not caught by the system. So you can see here in this image of this histogram here, there's a large prosthesis that was not recognized, right? And if it is recognized, you can see that the S min should be over towards the right side. But unfortunately, this is included, while the lead apron was caught. So the S min does not include the lead apron, but it does include the prosthesis, which can potentially throw off our overall contrast and brightness of the image. So in other words, the system doesn't always work perfectly, which is why we have to be careful, especially when we're working with patients that have a prosthesis. So here's something that I just kind of caught from the web, and this is the histogram analysis. It's important, really important, I've said this before, to choose the correct anatomic region, or what we call the procedural algorithm. And what can happen if you don't is you can get an image where the contrast is off, or the spatial resolution is not where it's supposed to be. For example, when we did this in the lab, some of us, and for those of you that didn't, I hope you'll have that lab soon. Um, we did a chest x-ray, first under a normal procedure. Then we did that radiograph a second and third time, first processing it as a skull, and then second processing that same chest x-ray where all the parameters were the same, including things like SID, collimation, our technique. The only thing that changed is the algorithm, and what we did on the third one is we processed it as a foot. That particular image, I think, was the most dramatic. It had increased spatial resolution, which at first sounds like a good thing, but it really wasn't because it was very noisy and pixelated. At the same time, the contrast was higher. That also, on the surface, might sound good, but really it's not. It was a short scale image. It was more black and white, but in a chest x-ray, you want a longer scale. You want there to be more grays to illustrate the many different types of pathology that you can have in a chest x-ray. So this was a result simply of choosing the wrong anatomic region on the menu, which can easily happen. Here's an extreme example, right? Again, these errors can occur even if the actual technique, like KVMA time, are appropriate. Procedural algorithms can cause some drastic results to occur. So we are nearing our last step here in the reconstruction of an image, right? After our initial histogram analysis, right, this raw image is created. Oftentimes you'll see this raw image just before it gets fixed. That fixing, we can now say, has a technical term known as rescaling, also known as normalization. So this washed out image that you see here on the right, you can barely make out that it's a chest x-ray, and you can see some leads and some wires in there, goes through a process known as normalization, which is an attempt to make the image essentially look more like a conventional radiographic image. So it's going to make those changes to the image brightness and to the contrast before you get a chance to do any post-processing, which, if you remember, was a term that essentially means we're going to create a pre-processing situation a second time, but under our will, not having liked the actual image that is rescaled. So how does this normalization process work? Essentially, there are several steps where you don't see A, B, and C necessarily. You're left with a final, quote, normal, unquote, view of what most people would find to be the appropriate contrast, right? So in an extremity, we were looking for a higher contrast, where, when we talked about the chest before, we were not, but we got it anyway. And also you're looking for a higher level of spatial resolution, where you don't want that so much on the chest, certainly not to the point that it becomes noisy. So we're left with this final image that is generally pleasing. And again, if we don't like it, and very often technologists will go ahead and try to window and level and adjust the image to make it a little bit better. We just have to be careful when we do this, because our monitors, as we've discussed, are not nearly the same as what the radiologists and physicians have in some of their offices, and potentially in the ER and the OR. So of course, rescaling is done utilizing software, and occasionally the software gets updated. We've gone through several updates with our plate reader from Konica, and one of the things that was first noticeable was that we went from having one procedural algorithm that basically covered hand, wrist, and forearm and elbow, to separate procedural algorithms for each one of those procedures, with the thought in mind that we're going to get better contrast, better brightness, and an overall better resolution, being that the math is going to be a little bit differently, looking at slightly different volumes of interest, understanding the collimation for each of those procedures, having an idea of what type of tissues we're utilizing. So those are some of the logic that go into new procedural algorithms. So in this rescaling, all of the data that is now from S-min to S-max. So remember, those S-min and S-max boundaries were determined earlier by pattern recognition and some of the other things we've discussed. And we are left with, let me just pause here. So in this rescaling process, we are left with a histogram, except now our S-min, S-max, and all the numbers in between are algebraically relabeled. So they just become numerals, essentially. And those numerals are compared to the lookup table. And for each sort of bucket of pixels at a certain brightness level, we're going to compare that to the numbers in the lookup table, which are known as Q values. So our relabeled S numbers are then compared to Q values. And of course, this is based overall and on that dynamic range of the software. So we can say, for example, that anything labeled as Q value 2 is going to have an output of a particular grayscale, right? That might go from 512 up to potentially over 1500, right? And that is going to take our pixels and their brightness levels and convert that to what is believed to be, based on research and the things that we've been talking about, the optimal contrast level and brightness level for that particular type of exam. So that concludes our lecture. Please remember that there are facilities at your disposal. If you go to our computer lab, you can be set up with the ASRT digital modules, which offer a lot of extra information and support, as well as on Blackboard. There are a couple of additional articles that you can read in the links section. Thanks, everyone.